Good evening. Black women in the United States have a lot working against them, according to research. They are 3 times as likely to die of a pregnancy-related cause as white women. They have the highest rate of obesity in comparison to other groups, and they experience higher rates of discrimination, which is a stressor related to poor physical and mental health. What's more, many Black women face barriers in the medical system. According to the Kaiser Family Foundation, people of color are more likely to face discrimination when seeking healthcare. If you have been a part of our discussions over the past 3 or 4 sessions, we've been really just focusing on Black women and their health. We started with adolescents and we talked about young women. And so today we're going to have a conversation as what we call grown women health advocacy. And for my co-host today, I am joined by Erin Kimball. Hi, Erin. How are you?
I'm good. How are you?
Good. It's so nice to have you as my co-host tonight for this discussion around grown women. Why don't you tell us a little bit about yourself?
Thank you so much. So I'm a graduate student currently in the field of school psychology, and so as part of advocacy in my field, so this talk couldn't be more central to who I am, what I stand for, and so I'm just happy to be here.
Well, we are happy to have you. And so, as always, for our sessions, our Women Health sessions, we are joined by Dr. Nalo Hamilton. Hey, Nalo, how are you?
Good evening, everyone. I'm doing well. Happy to be here. Thank you for having me again for this part of the series.
We are so happy to have you. And again, I would like to make sure that everyone understands that the reason that we have had these sessions is because of Nalo. She has suggested that in order for us to really have this discussion, it was really important for us to break them apart and to focus on these individual groups versus lumping them all together. And Nalo and Erin are both Healthy Heart Nation ambassadors, Erin in the areas of education and Nalo also in the areas of health and education, but with a primary focus on education. So we think that it's really important for us to have these types of discussions. And so with that, we will start with our first question, Nalo, for you. Go ahead,
Okay.
Erin.
Okay. So we wanted to just start with like overall women's health. So are there any tips that you have to help women maintain their overall health?
Okay, that's a really good and very broad question. So I'm glad we're starting big because when we're talking about women's health, it is more than what most people think of. It goes from the top of her head to the bottom of her feet when we're talking about her health. So if I'm going to start head, we're talking about mental health. So that's part of women's health. Women tend to be the central, the nucleus of a family or a community. So they're making sure everything else stays spinning. So they're making sure this ball goes here, goes there, but they don't always take care of themselves. And so when we're talking about the head, we have to remember, are you sleeping? Are you able to be present? Do you need to take a time out? Are you taking care of your own mental health? Meaning, are you doing things that bring you joy? Are you reading? Are you relaxing? Are you exercising? Are you coming out of your various entities? We have some women who manage at an office. There's some women who manage at home. And so you have to make sure that that's done. Also, if you move down from the head to the chest, we're dealing with especially heart healthy health. A lot of times women don't go and take care of their health. They make sure everybody else goes to their appointments, but then they don't go to their own primary care provider and get the heart checked out, the lungs checked out, their hormones checked out. They don't do that. And as I was reminded this week, when women present with cardiac issues, they don't present the same way that a male does. And so they're more nebulous things that we have. We might be nauseated. We might have a really bad headache. You might have a little bit of reflux. And so with that, we think of heart issues. Oh, I have a crushing pain in my chest. For women, that's not always what happens. And thus those symptoms are something that women will brush off all the time. What woman doesn't have a headache? I mean, feeling nauseated could have been something I ate, I wasn't paying attention to. So it's important for her to take care of her heart health, to make sure that she actually goes to her primary care provider, especially now that we're coming out of COVID. Some of us didn't do that. as well as getting our mammograms done, depending on if you're at age to do that. It's also important for a woman to do her own self breast exam so that she knows when things change. And that's from a young lady all the way up to the very season, because you should know the changes that happen. And as we move further down from the chest towards the area between the hip area, it is important for you to still see a specialist to deal with your gynecological health, even if you're past particular ages or before ages where they think that pap smears are important. There are still the pelvic exam you should have, even outside of a pap smear. And then we're talking about the legs. Yes, that exercise, that movement, that activity. It's very important for the rest of our body as well. And I forgot one area that's too is our GI health. Women don't always pay attention to their own GI health. Is it we're aware of what we don't, or we don't look as like we would in a dress or a pair of pants, but you have to understand the importance of that GI health, which also affects the rest of your body as well. So when we talk about women's health, it's from the top of her head to the bottom of her feet. It's not just in one anatomical space.
I think that's fantastic. Some of the things that you just mentioned are all very critical, and similar to what you were saying in terms of like heart health and how women present. And I'm not a doctor, but I play one on TV, and the words that I've heard previously is like the most common symptom for a woman of a heart attack is sudden death, right? So, there's no recovering from that one.
Correct.
So, and then as you referenced, you talked about the legs and everything. And so we also don't talk about a lot in terms of circulation, right? So some people, as they get older, they have more edema, they have more swelling in their legs and things of that nature. And it feels like that may be a symptom of getting older, but is there more kind of involved with something like that?
There's more involved with that. I mean, if you think about it, some of us use a vernacular and we say, oh, she got big ankles. Well, there's a reason why she might have big ankles. It's not because she was always wearing heels. Sometimes you have big ankles simply because your cardiac health, your cardiovascular health is not doing what it's supposed to do. There are some challenges with this. Sometimes you can have that because diet. You are eating too much of some things that are causing that to happen. We have bad circulation. Sometimes your circulation is also affected by the fact that you don't want to actually receive the fact that right now you're diabetic, and that affects certain things. It is not, as women, we tend to push off the things that affect us because we're too busy to take care of everything else. But we have to remember that in order to take care of everything else and everybody else, we do have to take care of ourselves. And we like to say, you don't miss anything until you lose it.
Right.
And so these are the things that we should always pay attention to. I have the opportunity to advocate for people. And there's one young lady that I was advocating for. She was like, well, I've had this and this keeps going on. I was like, wait a minute, what's your primary care provider doing? They should be doing that. And it turns out that they were like, oh, but you look fine. And I was like, yeah, that's not normal. And sometimes you need to advocate for yourself against the provider that you already have and to say, hey, I need a second opinion from you. This is something that needs to be done as well. This is a concern. Yeah.
Okay. Absolutely. Okay. Well, I will take the next question. So we were again going through and talking about, the overall health. And so how often should women conduct breast exams?
I say monthly.
Okay.
I'm getting, and that may change. And Dr. Lysett might have something to add to that as well, because it changes where you are in development. But I always say monthly, right after your cycle gets started. And then if you no longer have a cycle, which we kind of chatted about earlier, pick a day in the month to assess that.
I would agree with that. Patients always say, doc, when I check my breast, I don't know what I'm feeling for. It all kind of feels the same, right? And I say, you know what? That's exactly it. It's kind of getting to know what your breasts feel like. Because you're going to see me about once a year. I'm going to do an exam. If a patient comes to me and say, look, this feels different, This is different from what I'm used to feeling. You know, I'm going to take her word for it because she's checking her breast. So I would agree, yes, definitely at least once a month, you know, right after your cycle, not when your cycle is coming, because the breast tissue does go through changes throughout the month, you know, with the hormonal cycle. So I would agree with that with Dr. Hamilton there.
All right. Well, you know what? I'm like, we jumped in this thing and I forgot to even do introductions because we are all really kind of good friends. And again, Dr. Nadine Lysette is also a member of Healthy Heart Nation, is a health ambassador. So Nalo, I don't think I asked you to introduce yourself today. So let's start with you.
It's that whole familiarity thing. I think that's
I got too comfortable. Please forgive me.
Oh, it's okay. I am faculty at UCLA. I'm a women's health and adult nurse practitioner, but at the same time, I am also a scientist. I am a breast cancer researcher. Women's health is my thing. I also have the opportunity to educate nurse practitioner students as they begin their new phase of their career as being providers. So that's the brief bio.
Okay, thank you. And then Dr. Nadine Lysette, your introduction, please.
Well, I'm not as like Dr. Hamilton with all of that. That's fantastic for sure. I'm a board certified OBGYN. I've been practicing for about the past 20 years. I also participate in education with medical students, physician assistant students, and also nurse practitioner students from different programs. I specialize in all things women health for women, but I also specialize in minimally invasive surgical procedures as well, specifically robotics. I have a practice that's local here in town, and and I am definitely, a champion for women's health, and especially Black women, and and with all the different issues that we're having, definitely a champion for that.
And your practice is something that is new, right? You've just opened your practice.
It is for the last couple of months. Thank you. Right after 2 years, I did it, right? Yes, it is. We recently opened in February. It's called the Maven Group, and it's in Rialto, California. And, it's pretty exciting. I'm really happy about it.
And a beautiful facility. And we can't wait to do your grand opening. We are so excited about that. We'll talk about that later. But okay, Erin, your question?
So my question is actually for Dr. Nadine. So I had a question about how often women should be getting pap smears.
The guidelines for that keep changing, right? There was a time where we used to do pap smears on everyone every year. There was a time we would do them every 4 months, every 3 months or so. There was also a time when we would do pap smears on teenagers. Those guidelines have changed. So pretty much, we do the first pap smear starting at around age 21. It doesn't matter if you already had like 5 kids. We're not going to do a pap smear until you're about age 21.
Okay.
Between about age 21 to about 29, we do them about every 3 years. Starting at about age 30 and on up to about 65 or so, we're doing them about every 5 years, and that's the PAP and the HPV together. Now, starting in 2020, and Nyla, you can probably also jump in with that too. The American Cancer Society, they are advocating for us to start doing pap smear starting at about age 24, but actually just doing the HPV test. I would say the jury's still out on that. But, that other schedule that I mentioned before is more so what we do. Yeah, pap smears are important. Cervical cancer is one of those things that's very curable if it's caught early. And that's the whole point why we do pap smears, is to be able to catch things early. And so they don't sit and they don't fester. And so, and I always tell my patients, look, even though we're only doing the sampling of the cervix, the pap, that's only one portion of the whole entire gynecological exam. I want to see you every year. I want to check your breasts. I want to check your ovaries. I want to look at everything, your vagina, the outside, to make sure that everything is doing okay. We can talk about your sexual health, all of that. And so it's not, I don't want to see you, in 5 years, bye, see you later. No, it's I still see you every year.
And I think that's important to say, because most women just associate when they go to their gyne providers, I'm just having a pap. No, as Dr. Lysette has said, it's a lot more than that. And we do need to see you every year. Thank you.
Yeah, I mean, because when Erin and I were kind of going through the questions, and she was like, "How often?" She was asking the questions, and I'm like, "I don't really know." Like, right? So a lot of times we just rely on our providers to kind of send us those notifications. And so when you're with a good system, you do kind of get those. But it
Right.
sounds like, based on what you guys are saying, that it is probably optimum for women to maybe create a chart, right, or some kind of like racy chart, because I do project management, excuse me, but where you're just essentially kind of saying, hey, these are the things that I need to make sure that I check out throughout the course of the year or 2 years or 3 years or things of that nature, so that you don't overlook something that is important.
Exactly. And it's, it's more so it's your GYN exam. The pap
Okay.
smear just happens to be part of that. Just like you would go in every year to get your annual exam done with your regular doctor, right? To get everything
Mhm.
checked out. Your annual GYN exam should be thought of the same way.
Yeah, and it's so unpleasant,
Yeah,
right?
yeah. That's like when I tell people, I'm like, yeah, I know this is no one's favorite. I know, but it's necessary, and I
Maybe
understand.
you guys should think about like a TV with like the color purple playing at the top. We could just
Oh yeah, no, my patients and I, we just kind of shoot the breeze, and before they look
right.
like it's over, I'm like, it's done, girl, it's done.
Done.
Yeah, just keep it conversational, right? Keep
Oh
it
yeah, we're
light.
talking about all kind of stuff. Yeah.
All right, fantastic. Erin, is it my turn to ask a question? I think so. All right. So Nala was like, when is my period? The question is, when should we expect that our periods will end?
You don't know. It's
Dun,
a surprise.
dun.
Fruit basket upset. It can do what it does.
Yeah.
So we like to say you can look at your aunts or your mothers to get an idea of the range of when you might start seeing a change or an ebb, if you will,
Okay.
from your menstrual cycle. But you're also at a disadvantage because we have women who have had hysterectomies. So
Okay.
you don't have, so they stopped having menstrual bleed because they had the hysterectomy. So if you have those, a lot of those women in your family, you don't have an idea. It can be as late as your late 50s. It can be as early as your 30s. It depends on what's going on. So
Okay.
I
yeah.
would, I would say the average age, in general is about age 52. So the average, just the middle number, right? So some
Okay.
women definitely before, 50s, their late 40s or so forth. I would say in your 30s is definitely premature, and we need to figure out why that is.
Okay.
But then you can be as late as up into 57, 58. And yes, like, Nilo said, looking at what your other family members did would kind of give you also an indication as to when you'll go through it, which kind of, leads me into this segue of something that, I'm probably going through. I'll be the first thing I'm going through it. And, patients talk about it all the time, is this whole perimenopause. What is this?
Okay.
Yeah.
This kind of time before the menopause where you're getting all these symptoms that feel like menopause, but you're not quite there. And those
Right.
symptoms can start anywhere from like 5 to 7 years before the true menopause. And so it's kind of like an up and down. And, I tell the patients it's kind of like an up and down of your hormones. So
Okay.
sometimes you'll get like, some women will get like hot flashes. Some women will start to get night sweats. You'll start to have menstrual irregularities. And there's really no rule for that. Some women, they're bleeding on and off all months. Some women are skipping months at a time, and then it's heavier.
Mm-hmm.
And will start to see changes in sex drive. But then also you'll start to even sometimes increase symptoms of like PMS. And, I tell my patients, our periods start with a vengeance, and then they, and out with a vengeance. They want you to remember that it was there. And then also changes in our metabolism starts to happen at that time,
Yeah.
that with our stress and cortisol levels, weight gain and all of that. So that's this whole perimenopausal time. And that's usually somewhere about 5 to 7 years before your
Oh,
actual menopause, right? That's
no, I'm sorry. My face
I'm
just
there,
did
girl.
not.
I'm
My
just,
face
I'm with
just,
you. I don't know who else is there.
hey, but you know what? There's something else that Nadine says as well, is that's perimenopausal. Menopausal is when you have gone without your period for 12 months.
Exactly.
So when women say I'm menopausal, I was like, wait a minute, you stopped having your period for 12 months? No, I'm doing. Then you're perimenopausal. That's what we're negotiating, because when we hear you're menopausal, and then you're
Right.
telling me that you're having vaginal bleeding, I'm starting to think about a whole different thing. I'm
Okay.
thinking about, oh, I got to do this workup, and I'm possibly going to have to send my patient to someone like Nadine in order for them
Right.
to have some other procedures to be done or to be assessed. So I think it's very important, as she's pointed out, what terminology to use.
Yeah.
Is that you have perimenopausal symptoms, and yes, they can tap on your last nerve, like she said, for 7 years before they're like, okay, we'll let you go now. But you know,
Right.
it's the same time.
So it sounds like we are technically using it wrong, right? Because the menopause is when it stops.
For
Correct.
12 months. For
For
12
12 months.
And then
Okay.
also that it would have to be confirmed with laboratory testing. So it would
Okay.
be confirmed 12 months that your estrogen levels are lower and your FSH levels are higher.
Yeah.
Right?
Okay.
And then that's truly menopause.
And so when you've had menopause, or when you're in menopause, do you still have the perimenopausal symptoms, or are you done with it all?
So the perimenopausal symptoms are very similar to the menopausal symptoms. They're just not all the time.
Mhm.
Right. So you still may get the night sweats. You still may have the sleep you don't sleep like you used to, right? You still may get the hot flashes sometimes during the day, right? Those are the same symptoms that you get from menopause. The perimenopause are kind of on and off sometimes, depending as to where you are. Your hormones are kind of doing this.
Mhm.
And so the cure is
There's no cure.
I mean, a lot
There
of
are things
times,
you can mitigate.
such
yeah.
as do share.
Well, I mean, every patient is different.
Okay.
There's some patients where the symptoms are just so bad it's affecting their everyday life. That's why I tell patients, look, if you're not able to function, then then we can do something about it, right? And so if the periods are so irregular, they're having heavy bleeding, it's unpredictable. Sometimes we have to regulate patients with hormones. Sometimes we'll put them on like a birth control pill to kind of keep their hormones at more of an even range, and it stops the hot flashes and it stops the sweats. And then, and I tell them, I said, well, it's just kind of masking things, but it kind of helps them to function. And they'll say, well, how long do I have to stay on this? Well, we can stay on this until we get closer to that average age, 51, 52, then let's come on off and then we'll see where you are.
Mm-hmm.
So you can tell by my face that I'm experiencing these
got
things. I thought I was just going to ignore it all and it would just go away. It's just a couple of weeks. I'll just bear through it. But yeah, this is there's got to be a light at the end of this tunnel that you could share with. I'm asking for a friend.
For a friend.
Well,
I mean, for everyone is different. And like I said, I mean, besides hormones, I mean, definitely decreasing stress, exercise, dietary, changes can help, but it can help definitely quite a bit. But, it may not necessarily be perfect, but it can help. It can help to decrease some of those.
I'll make sure I share that with the people who would want to know that kind of
thing. Because see, some people, we talk about cure. There isn't one. We just manage symptoms.
Exactly.
Sometimes we as women get a little bit older, and you see the meme of it's the end of the day, I need my wine. And I have to tell patients, I think you might want to push away from the wine at the end of the day, because your power surges can start happening more because of the alcohol.
Yeah.
So when we're talking about diet, some of the things that might cause pleasure at the palate do not cause pleasure within the body. So, and you learn those things that are triggers for you.
Okay.
So there's things that we can negotiate, and every person is different. I happen to be talking to someone today, and they're like, "Oh, I've got to go drink water, got to get in the shower. I am having a sweating experience right now." And I was like, "Oh, really? Yeah." and I'm like, doo. So and this person is younger than myself, and that has not been my experience.
Okay.
Everyone
so that is just showing the variability.
Okay.
It's not the same for everybody.
Mm-hmm. All right. Well, I'm going to turn it back over to Erin so she can ask some different types of questions.
I was gonna switch it up a little bit. I was gonna actually ask you about fertility. I know that some women, might struggle with that, and so I didn't know if there are any tips or ways that you can possibly increase fertility potentially.
Yeah. The thing about fertility, is trying to find out, what's the reason for the infertility. That's the first thing that we do in evaluation, right? And so we'll ask a list of questions to find out kind of like how your cycle is, see about your past history, to see, we'll do evaluation to make sure there's no anatomical changes such as fibroids or polyps or things. And then also the very important thing, many times we got to check the husband, right? Because many women will think that the infertility issue is theirs when it's, it may not necessarily be their problem alone, right? I think, to be able to increase fertility, I would say is definitely finding out, what's getting to the root of what might be causing the infertility is what I would say. Now, the one thing I will add to this, usually we'll tell people, oh, try for a year. And if it doesn't work, then come see me. Well, I think if you're less than 35, sure. But once you get to 35, I wouldn't recommend that you do that. If you've been trying for about 6 months and nothing is happening, I think that you need to at least go have a conversation with your gynecologist, because, women, we're born with every egg we're ever going to have. So when we're 35, our eggs are 35 years old. When we're 37, and so forth. And fertility just does start to decrease.
Dr. Lysa, could you please explain to people what is trying? Because people say, well, I had sex. No, I need for us to explain what is trying.
That's a really good question.
You know what is trying?
You know what? Obviously, trying is that you have to have regular intercourse, at least 1 to 2 times a week, right? I try to, tell the patients not to get too caught up on, okay, this is my cycle time. This is my ovulation time. I'm going to
temperatures.
Right. Put my legs up. Yeah, that can help. That can help. But, sometimes, especially if the couple's not getting married, getting pregnant, I think that puts a lot of stress, on the marriage sometimes, and so I tell them, I said, look, just have a good time. Look, this is roughly your fertile time, but have sex all month long. It has to be on a regular basis. You can't get pregnant if you're not having sex.
Thank you.
Right.
And many times we see that, but try not to put too much pressure on it, go out on a date or something, go have a good time, go dance, then
relax.
Take a vacation, right?
Exactly.
A trip.
Things of that sort, because it puts a lot of pressure on a marriage when infertility is there, and I see that.
Because couples like to say, well, we're trying. And then we ask them, how often do you have sex? Oh, like once or twice a month. I was like, well, then you're missing a whole lot of opportunity.
Exactly.
That's not helping you to go towards your goal. And I think there's another thing that we also have to look at too, is sexually transmitted infection history, because we have some individuals who have had sexually transmitted infections and they forget about them until we're having to deal with fertility.
Yeah.
And they can be younger. And when we're asking the history, and then all of a sudden you have an exam done and you're like, this doesn't look as anatomically appropriate as we expect. And then they're like, oh yeah, I've had chlamydia 4 times. And you're like, well, we should have talked about this. So then we have other things that we have to talk about. Or I have, I don't have a regular period. So you're coming to me up in arms and I'm asking, well, you have a period? Yes, I have a period. Correct answer. They do have a period, but having a period or a hormone withdrawal bleed, which allows the body an opportunity to ovulate, you only have that every 4 months. So we got to do something else. So it's important, along with that, to have a candid conversation with your provider. This is not the time to hold stuff back.
Yeah.
Right.
Yeah.
Okay. Thank you. So the question is, and I think this is for both of you guys, but Nala, if you want to go, you can start this one. Does exercise and maintaining a healthy weight have an impact on health outcomes?
Yes. It absolutely does. And so, and I'm glad you say healthy weight, because there's some bias sprinkled in there like pixie dust. What is a healthy weight? And in our culture today, I gotta pause, because
throw out the BMI chart. Don't even look at that.
Yes. And then the other thing you have to think about is sometimes people are saying, well, I can do this now. And we as folks will say, okay, well, your body can handle that. But we're looking at the long term. Your body's showing me indications of that's not a healthy weight for you.
For you.
Right. And that's what I said, for you. It's not. I like to do I'll kind of like go back to the fertility question. I've had patients who've gotten pregnant at 210 pounds, and I have patients who cannot get pregnant at 150. So the weight is for them. What can we do? So sometimes I'm like, okay, for the young lady who got pregnant again, at 210 pounds, she was struggling. We got her down to 200. She conceived. But we kept her at that point and she didn't have an issue. Whereas my young lady who was 150 pounds, because we're looking at a number, we had to negotiate some other things. So that is individual. And that's the same thing with a healthy weight. When you aren't able to do certain things and your body systems indicate to us that there's a challenge, then that's when we're like, this is not a healthy weight for you.
Okay. And so even in those instances, like the weight dropped, but chances are, as a result of the weight dropping, maybe the blood pressure dropped, maybe the cholesterol, some other things may have.
Those are other things, because I can have a young lady who is in her 20s at 110 pounds or 210 pounds. Neither one of them have blood pressure issues. Neither one of them have cholesterol issues, no respiratory, no cardiac issues, nothing. I can also have a woman who's 32 who weighs 135 pounds, and cholesterol we are fighting to manage. So there are different things that can go on. Yes, your diet does help to compensate those things, and it allows us to have the body is remarkable, so it can help to do things to balance out. There's juxtaposition in different areas. I mean, you can have someone who looks really well and their cardiac function is a mess because visually. So again, it depends on who you are and what your body system is telling us.
Okay. And so, Dr. Lysette, in terms of your practice, how does the healthy body weight, what do you see in terms of the health outcomes of your patients?
Well, as I'm a gynecologist, so of course I'm, specifically dealing just with, with women. And so the issues that I'll see many times when women come in with issues of weight is irregular periods. I will see something that's called endometrial hyperplasias, where precancers of the uterus, even uterine cancers that's related to patients' weights. I'll see infertility. Many times PCOS, things of that sort that is related to the patient's weight. And so, what I tell my patients is this, especially specifically the ones with infertility, irregular periods, PCOS, and things of that sort. As we talk about weight, I say, so your body doesn't like this weight. It doesn't mean that I want you to be 100 pounds. But as Nyla was saying, everyone's body's a little different. For you, a 20-pound loss may make a difference, or a 50-pound loss may make a difference. But just getting you to being the healthiest version of yourself will help overall with your overall health, with your heart function, with your kidney function, with your lung function, and also help that you'll be healthy enough also for pregnancy too, to be able to decrease some of those risk factors that can occur with obesity and pregnancy, diabetes, hypertension, and things of, to name a few. Okay. So I would say that it does make a difference. When I mentioned earlier about throwing out the BMI chart, where I was talking about, well, her BMI is, and her, look, it's different for everyone, right?
Absolutely.
The BMI may say that you're overweight, and you look at that person like, there's no way you're overweight. So
right.
I wouldn't even look at that. It's more so, as Nyla said, what's healthy for your body, and it's different for everyone.
Understood.
But I would say in general, I don't think the body likes to be overweight. In general, I mean, it puts a lot of stress on your joints, and it causes your organs to have to do a little bit more work. So, being obese, I would say the body, doesn't really, I don't think the body was designed that way to be able to carry weight for long periods of time.
Okay, thank you. Erin?
Yes, so you kind of touched on how weight does impact, pregnancy and fertility and all of that. And it kind of segues into my question about, why Black women have the highest maternal mortality rate in the United States, and just, some of the risk factors that might be related to that.
Yeah, you want to start with that, Nalo? I mean, I got a whole lot.
No, I am going to let you start. and you might even finish. I'm just going to be a cheering section because I mean, you know, that's a whole hour-long discussion.
It is. There's so many different reasons, and I mean, and Danette has heard me talk about this, several times. So let's talk about us, specifically, Black women specifically, right? I would say that sometimes it's other risk factors that we might have, hypertension, obesity, diabetes. We're coming in with some of these illnesses. I would also say is that we don't always pay attention to our symptoms. I call it I don't got time for this syndrome. I don't got no time for this right now, so I'm not taking care of this. So or they don't want to know. Don't tell me I don't want to know. So I would say definitely that does play a role. There's a lot of mistrust, just with Black patients and the medical community. And then also, unfortunately, we have these biases. From the medical community.
Absolutely.
And many of these biases we don't even know that we have, right? We kind of make assumptions about patients when they walk in based on how they may speak or how they may, look and so forth. And we're not really taking them seriously. And in my personal opinion, and just dealing with patients of all races, I would say, I think Black women, unfortunately, Black people in general, sometimes, allow themselves to be dismissed pretty quickly. It's kind of interesting, Hispanic women, they don't want you to give them too many choices. They want to say, okay, doctor, what you want me to do? It's cultural for them. Which one do you want to do? Okay. Some of my Caucasian patients, they want to know every choice, every option. They are in the driver's seat. They want to make the decision. My Black patients, it's almost like you'll sometimes have to draw the history out of them. You have to be patient. You have to be able sometimes to see past some of the other things that they may be coming with, the fear and how that's manifesting during that interview. It may manifest as an attitude. It may manifest as, they don't know how to answer the question. So you have to be very patient to be able to get the history to put it together. But they will allow themselves to be dismissed. Oh, I'm having pain. Oh, you're not having no pain. And then they don't really say much else about it. While I'm having pain and you need to bring me something right now, because
they'd rather hear that than that something is wrong with them, probably,
exactly. Right. Because they don't want to admit that something's wrong. I have this one beautiful patient. Well, my goodness, there's so many stories. I mean, I've seen this beautiful Black woman I saw in the ER, educated woman, she is a professor at a university and postmenopausal, had been bleeding for a very long time, but didn't want to do anything about it because I ain't got no time for this and I don't want to know. Until she ended up in the ER with a big mass growing out of her vagina. Unfortunately, by that time, there was not very much that we could do because the cancer that was spreading and growing, out of the vagina. So, we got to listen to our bodies and, and we have to, we have to advocate for ourselves for sure. I know you all were talking about that a little bit earlier, seek second opinions, but then also from the hospital side and the medical community, there's a lot of work we have to do. We have to deal with our biases. We do. And we have to, find better ways of reaching all patients, not dismissing patients.
Well, I also think that as Black women, we've grown accustomed to not being heard, so we don't speak up. So we ourselves have to be at the point where we will advocate for ourselves. We'll advocate for our kids. We'll advocate for our parents. We'll advocate for everybody else, but we don't advocate for ourselves. And I said, that's why it's important for you to have a candid conversation.
Right.
When you come in, there's a need to have a candid conversation. If we become dismissive, you need to hold us accountable.
Yeah.
You're not listening to me. And that's perfectly okay for you to say.
Exactly.
You're not paying attention. You didn't even look at my vagina. So how would you know?
Are you going to
explain
me? There's nothing wrong with asking that.
That's
but
right.
We'll add, in the number one killer with Black women and maternity is hypertensive disorders. So that's whether that's having high blood pressure before they were pregnant, developing something that's called preeclampsia afterwards, which can have, weird symptoms. They have a little headache, little blurred vision. They're not thinking anything of it, but it is it's quite dangerous. And so that, out of all things, is the number one reason why for mortality in Black women. And then also hemorrhage, bleeding afterwards is the other reason. And there's a lot of different factors that go along with that, not getting the proper care in the hospital, not following up, but also things, fibroids. I mean, there's lots of different reasons that contribute to that as well, but those are the most common.
And it's in terms of like advocating, right? Like, I think a lot of times, number one, like, we are fearful of the doctors going into the hospital. We'd rather not hear bad news.
Yeah.
Right. So if they are saying, "Oh, you're fine," it's almost kind of like what you want to hear in the first place.
That's why you dismiss it. You're like, "Oh yeah, I'm fine. Okay, thank you."
I knew it. I knew they were going to tell me I was fine anyway. So from now on, it's like, why do I even go? Because I'm fine, right? I know I'm going to be fine. You want to be positive about it all. But then there are also like some personalities where you don't feel comfortable advocating for yourself.
Right.
So do you all recommend that, that when you're going in to, bring someone else who can maybe take the emotion out of what you're hearing or what you need to have addressed, and can advocate on your behalf if necessary?
Yeah, I think so. I mean, it's unfortunate. I've had patients have to come in and do that. And I'm saying, and I tell them, I said, "I'm so sorry that you felt this way, that you felt that you had to do this." And I said, "But I understand."
Okay.
Yeah. I mean, if you feel that, you've gone to your appointments, you're not really getting the answers that you want, there's nothing wrong with having someone there with you, but I would say, but it's all in how you do it. It's being respectful. You don't want to come in a manner in which that you're attacking, but there's nothing wrong with questioning. And if you're not getting the answers that you think are correct, get a second opinion.
And so Nadine, can you give us like an example of an attacking response and an asking response?
Well, I mean, like I said, we're very, Black women, we tend to be very spirited,
Yes.
We're very spirited, and that's part of our charm, and and it's beautiful, but sometimes it's a little different, if you're with the neck rolling, well, that don't make no sense, and well, that's wrong, and I mean, it's just all about how you do it. I mean, if it's you're raising your voice, you're yelling, whoever the healthcare provider is going to be taken aback by that,
right?
No, they're going to immediately be on the defense.
Okay.
And, because you can have a conversation, you can ask anyone anything that you want, but it's all in, it's all in the manner in which that you ask, right? And very clear, very poised, and they'll get the message that, okay, I'm not really happy with what you're telling me right now, but you're not coming across that, you're attacking.
Okay.
And what I think they also, we as providers understand that this could be an anxious situation. And because you're not our only patient for the day, we are aware that sometimes our appearance is very sedate. May not be as engaging as you'd like us to be. And partly it does matter when in the day I'm seeing you. And also, if I have a result I have to discuss with you, I already know that this can go left. So I'm coming in to say, let's have this conversation. And I'm trying to, figure out where you're going to land before maybe I become or appear to be more approachable. And I think that's something that also needs to be understood. By and large, attacking a provider could be anywhere from saying, Google says this is what's wrong with me. And since you're not going on with Google, then you don't know what you're doing. To the point that you're becoming physically aggressive, which I've had. To the point of you've picked up something in my office and you're like, if you don't do this, I'm like, see, I don't think you want I have this education, but I also know some other things. We don't want to do this. This is not what we want to do right now. Because depending on what it is, not getting the answers that you need in advocacy on another thing, I recommend to patients to write your questions down.
Absolutely.
Before you get there, because there is the chance that you get an answer. And I had someone say this, I was told one thing, and as soon as they told me this, I stopped listening because I was stuck here because I thought I'm gonna die. This is gonna happen, blah, blah, blah. So you have to also understand, did you stop listening to me? So maybe it's time for you to repeat. This is what I heard. Because I may have given you some other options of what could be done, and this is where we're gonna be, and you're still stuck at the beginning. So I think that not only do we as providers can take some initiative to do better, because there's always places for improvement on our side, but also patients need to also be responsible for what it is that they need. And that comes back for advocacy. I need to advocate for myself, but advocating for yourself also means that you're able to work in partnership with someone who is there to help you to get the best health you possibly can have.
Right. And you took the words out of my mouth, because I was going to say, in terms of, the partnership. So what role does having a healthy blood pressure have on future health outcomes? And what is a healthy blood pressure?
A lot. I've been doing this. Okay. Healthy blood pressure, preferably, is less than top number 125, bottom number 75. So when you start having the top number that's 130 over 80, there's some things that we need to start talking about, because the body is telling us, I'm working a bit hard. Okay. Top number, it's easiest to say, deals with the top part of your heart. There are 4 chambers. There's 2 at the top, 2 at the bottom. Bottom number tells us how hard the bottom part of your heart is working. So we can have those patients where the top number is really good, we can say less than 128, but that bottom number might be sitting at 95, 98. Problem. Because that lets us know that bottom part is working really hard, and they're the larger part of your heart. They're responsible for pushing the blood to your lungs and to the rest of your body. And sometimes those numbers can be off because of structural issues with the heart. It could be due to you having high blood pressure, simply because we can do diet modifications, weight gain, etc. And it could also be that those numbers go up, ladies, as we get older. If you can go for years and not have blood pressure issues, you turn 62 and it's like, hey, you have high blood pressure. It can also be a result of aging.
The thing about high blood pressure is that you don't always feel it initially, but it's just wreaking havoc. Imagine that your heart is pumping out and those vessels are real tight, and it's just that hard pressure and it's beating your kidneys, it's beating your heart, it's beating your organs. And I tell my patients, like, the body takes a licking for a while, but then when it finally decides it's had enough, it breaks down really fast. And so, so I would say it's very important to manage your blood pressure, even if you're not feeling it. Oh, they say I have high blood pressure. I didn't feel nothing. Okay, but you have high blood pressure. We still have to manage this, because even though you don't feel it now because your body's compensating, it's it's destroying your body. And you don't want to get to that point later on where now your kidneys are done, so now you need dialysis, or now your heart is thickened. It's the muscle is thickened because of the pressure, or you're having issues with your lungs because you don't want to get to that point where the body's like, okay, enough. So I would say it's very important to maintain a healthy blood pressure.
Okay, and so you guys had mentioned kind of what that number is, and so in time, I mean, is it like something that has to be taken advantage of immediately, or are you how soon do you need to respond to issues with your blood pressure?
We're not gonna diagnose you with high blood pressure with just one value. We're gonna want to check it again, right? Sometimes we may have you do a log and then we'll follow up and we'll say, okay, let's see what your numbers are looking like, right? All right, let's go ahead and try to make some lifestyle changes. If you have some weight to lose, let's do with that. Let's make some dietary changes. Let's see what we can do here first. Now, if none of that's working, your blood pressure is still up, then yeah, we need to do something. We may need to get on some medicine, because we don't want it destroying your other organs, which may not be causing a problem now, but it can cause a problem later on, right?
So that's important for you to understand as well. So Nadine says, we're going to do some things. You don't have 6 months. You don't have 8 months. We're going to be working with you monthly.
Right.
Because if we can bring this down 3 to 4 months and we find what that sweet spot is for you, then fine.
Right.
But it is challenging when a patient says, oh, well, I was told I was pre-hypertensive. Okay, how long ago was that? 2 years ago. Well, that changes how I'm going to manage you today, especially when I'm looking at the numbers that I have right now. So again, advocacy for your health are two things. Once you are aware of something, I can't go home with you. You're going to have to take that upon yourself to say, okay, they told me this. I'm really not a fan of drinking a whole lot of water, but I'm going to try to do it by doing this. I really don't find time enough to exercise. I'm not going to the gym. I'm not doing this. Well, then maybe you just need to walk, that 30 minutes of downtime before you go into the house and deal with everybody else. How about walking then? You got to advocate for yourself, not only when you're with your provider, but also when you're with yourself, so that you can manage those things, because we can't go home with you. We cannot be your personal coach 24 hours a day. And it's interesting. My more seasoned patients want to say, I'm tired of taking all these pills. And I'm like, well, some of these pills we can negotiate. Some of these pills are non-negotiable. And so, and part of that is an aging issue. Part of that could be what's going on with them. But also it is very challenging to try to negotiate and to help a patient be their best self when they are not navigating or advocating for themselves when they're not with us. And so it is, in a sense, ideally it should be a relationship with your provider, so that it is actually a collaboration where you should know yourself and be aware of your body changes, but also have a trusting relationship with your provider to understand that they do want the best for you. It's not always ideal. We understand that. I've had to look for different providers for what I need. I tend to be a little picky, understandably so. So there's things that I look for, but when I find them, I keep them. And I try to be that for my patients.
Fantastic. Well, we are coming up on the last 7 minutes of our program tonight. And so, Erin, I think you may have one more question that maybe we can get to before we close it out.
Yes, I actually had a question as far as some of my curiosity. So I know that people that might be pre-diabetic can kind of reverse that. So I was actually curious if you can reverse hypertension or even high blood pressure, and just kind of some information around that and what people can do if they are in those situations.
For me.
I was going to let you go and then I'll follow up.
Okay. Yeah. Yeah, there are things that you can do. Yeah, I mean, some of it is genetic, and like I tell my patients, look, sometimes we're just genetically prone, right? You'll see someone who's thin, who exercises all the time, and they'll still have high blood pressure. But I would say definitely just lifestyle changes, taking care of your body, because you may not necessarily be able to stop hypertension from happening, but it'll make a difference as to if you need to be on a whole bunch of medication, right? You may not necessarily be able to stop diabetes, but do you want to just control it with just your dietary changes? Or do you want to have to take insulin? Right? And plus pills, so taking care of your body, making these lifestyle changes early on, I would say would help, decrease as to how much it's going to impact you, if it's even going to impact you at all.
And it's very true. It also depends on why you have the hypertension. So we have those patients who might start a birth control pill. They were fine. We have them come back for 3 months and that blood pressure is high. Well, more than likely it's due to the hormones that we've given you. So we can adjust that.
Okay.
You have those who can become, you have more blood pressure issues when you're pregnant. And then once you are no longer pregnant, then you're not hypertensive anymore. It's something that we do follow. You can have body weight. So we talked about that weight. You can reduce weight. For some people, it does make a difference. And then there for others, as you know, it is not. We don't know the exact genetic component. We just know that it does happen. So you can be 135 pounds and everything else is normal, but you have hypertension, and we manage that. And what's important, as Nadine said, is the fact that we need to manage that. Even though it might be one pill right now, it's better than the 10 that we do have available. I mean, because what we're trying to do is to make sure that we're managing body systems, because they all work together. It's a concert event. It's not any one system is a standalone. They all work together. And one of the things is, if your blood pressure is high, that means blood's not going where it needs to go. And what the body will do is it will eventually put you down. We would prefer that it puts you down gently. But for women, because we don't always pay attention to that, it puts you down hard, and that's permanent. And we don't want to do that. So it's important for women to pay attention to that. And when we start you, we'll work and negotiate, and there is just some adjustments, some things we just have to do.
Yeah. Fantastic. Okay. Well, thank you all for joining us. I'm going to go around just really quickly to see in terms of any closing thoughts, and then I'll close this out. So Erin, we'll start with you.
I'm sorry?
We'll start with you for closing thoughts.
Okay, yes. So, I mean, I think I just learned so much today. I think I knew some things, but I think that there are things that I will continue to learn. And, as a young grown woman, I think that, you guys are setting the tone for me to even start myself and have the mindset to pay attention to myself, be self-aware, and just really prioritize my health now. And that will only, help me in the future. So thank you for all the information that you guys provided today.
Fantastic. Thank you, Erin. Okay, Nalo?
It's never too soon or too late to start. Paying attention to yourself, being aware of your body, being aware of the changes, and being aware of what you need. Advocacy is a full-time event. You know yourself better. Work to create those relationships with your provider that are actually collaborative. But at the same time, even if you're in an environment where you don't feel as collaborative, don't be silent, because you need to know what's going on. So you're going to have to advocate for yourself.
Fantastic. Dr. Lysette?
And I would say, love yourself, definitely. And that means, take care of your mind, take care of your body, and, don't put that on the back burner. Don't put it off, because, without you, no one else is good, right? No one else in the family is good. So remember, you got to take time for yourself and show yourself some love too.
Absolutely. Thank you all so much for joining us tonight. This exceptional panel and my wonderful co-host tonight. I enjoyed the conversation, and I always learn so much from these conversations, whether I'm asking for myself or a friend. But it's very important that we just learn, because I feel like the more we know, the more we can do for ourselves and for others, as you guys have all touched on. So we ask that you all continue to support Healthy Heart Nation. Please go to our YouTube channel and look up Healthy Heart Nation. Please like and subscribe this video. And if you do subscribe, you'll get notifications on when we're doing another video, which we're actually scheduled to do tomorrow at 4 p.m. Pacific Standard Time, 7 o'clock Eastern. And we're going to just, that topic of discussion is the Invisible Woman, Black Health Advocacy. So we really want to just kind of talk about the disparities within healthcare and what a lot of Black women experience and what we can do to change it. So thank you so much for your time, and have a wonderful evening.